Hello, I'm Dr. Maury Markman from City of Hope. And in this and the next two segments of Minutes with Markman, I would like to talk about several abstracts that were presented at the recent European Society of Medical Oncology, ESMO meeting, which there's so much material there, but three abstracts that I picked out in particular that I think are just demonstrate the quality of science and the continual very positive change in our standard of care and paradigms based on this science that's presented at national meetings like ESMO and ASCO. I should note that it does appear to be increasingly a very friendly competition between ESMO and ASCO, as you expect, but I think this only heightens the interest in both in oncology, but also in the lay media, in the kind of science that's being done in the oncology community. So, paper to be presented today from my own clinical and research interests in ovarian cancer. Paradigm-changing study. Pembrolizumab versus placebo plus weekly paclitaxel with or without bevacizumab for platinum-resistant recurrent ovarian cancer. Results from the randomized, double-blind, phase 3 ENCOT Keynote B96 study. It was many years ago that the randomized phase 3 trial known as Aurelia revolutionized the care of patients with platinum-resistant ovarian cancer. In fact, prior to that study, which looked at the combination bevacizumab with one of three standard chemotherapeutic agents, the treatment of platinum-resistant ovarian cancer hadn't changed in decades, and in fact, could be described as overall dismal, single agents, one after another, and there had been dozens of randomized trials conducted. Aurelia changed that. And since that time, there had been new drugs have been added, but this backbone of paclitaxel, which was the one drug of the three, the other two drugs were topotecan and pegylated liposomal doxorubicin, but the one drug paclitaxel with bevacizumab had the most impressive outcome of the three in this randomization, including impact on overall survival, although that wasn't able to be specifically claimed because of the limited sample size. Nevertheless, it was recognized that bevacizumab added something substantially to the benefits of single-agent paclitaxel in platinum-resistant ovarian cancer. So this particular trial I'm mentioning now built on that backbone. There have been considerable preclinical data suggesting that paclitaxel itself, and this is data that goes back decades, that it can enhance immunity by inducing cell death. It impacts the tumor microenvironment. It can enhance antigen presentation and reduce regulatory T cells. Again, preclinical data, very provocative, not really clear what you can make of it, but the potential opportunity for checkpoint inhibitor to be combined with this drug to favorably impact outcome was real. I should add, and I think most of those in the oncology community know, that the use of checkpoint inhibitors in ovarian cancer has not really occurred because multiple randomized trials have shown limited benefit. So you might say, okay, well, why might this work? That's what the trial was attempting to address. So the key eligibility criteria, again, this is a very well done study. Results are incredibly provocative. Histologic confirmed epithelial ovarian cancer, fallopian tube cancer, or primary cancer of the peritoneum, 1 or 2 lines of prior therapy only, and at least 1 platinum-based chemotherapy. Patients were permitted to have received a checkpoint inhibitor, not many do in ovarian cancer, PARP inhibitors, or bevacizumab. Patients had to have demonstrated radiographic progression within 6 months after the last dose of platinum therapy. ECOG performance status of 0 to 1 was required. In this study, they stratified patients for prior bevacizumab use, yes or no. They stratified for prior delivery, they were stratified for giving bevacizumab or not. The doctors decide where they were going to give this. This was plus or minus bevacizumab, not randomized, study was stratified. They stratified for the region of the world, and they stratified for expression of PD-L1. Patients received the experimental arm as pembrolizumab plus paclitaxel plus or minus bevacizumab. That was a choice. And the control arm was paclitaxel plus or minus bevacizumab and placebo. Primary endpoint was progression-free survival by RECIST criteria. Baseline characteristics were equal between the two groups. About a third of the patients had high expression of PD-L1 by CPS, although again, in ovarian cancer hasn't had really much meaning at a clinical level. About half of the patients had progressed within 3 months of platinum therapy, so this was a pretty resistant population. And about half of the patients had previously received bevacizumab, and about a third of the patients had previously received a PARP inhibitor. 60% of the patients had received 2 lines of prior chemotherapy as permitted in the trial. Here's the bottom line. Progression-free survival, and they looked at this in both the intention to treat population as well as in that population that had some evidence of PD-L1 expression. But in the PD-L1 expression group, progression-free survival hazard ratio in favor of the use of the pembrolizumab, hazard ratio 0.72, the p-value of 0.0014. 12-month progression-free survival was 35.2% with the use of pembrolizumab versus 22.6% in the population that received the placebo, did not receive pembrolizumab. As noted, highly statistically significant difference. If one looked at the intention to treat the entire population, independent of PD-L1 expression, the hazard ratio is actually slightly better. 0.70 with a p-value of 0.0001. 12 months progression-free survival was 33.1% with the pembrolizumab versus 21.3% in the placebo group. Essentially, an additional 10% of patients had not progressed by 12 months if they received the pembrolizumab. If one looked at the progression-free survival either by PD-L1 expression or by intention to treat, and various subgroups, if they got bevacizumab, didn't get bevacizumab, prior bevacizumab use, prior PARP use, it didn't matter. All of the groups benefited in terms of delay in progression significantly with the addition of pembrolizumab to the paclitaxel regimen. Again, whether they received bevacizumab or didn't receive bevacizumab as part of this regimen. Key secondary endpoint in this trial was overall survival. And what the study demonstrated was a hazard ratio in favor of the pembrolizumab treated patient population of 0.76, p-value of 0.0053. 12-month overall survival, 51.5%. This is a platinum-resistant population. And as noted, a large percentage of these patients progressed within 3 months. 18-month overall survival. 51.5% in the population received pembrolizumab versus 38.9% in the population that did not receive this agent. 51.5 versus 38.9. Clearly a meaningful difference in overall survival at 18 months in the population that received the checkpoint inhibitor with paclitaxel, with or without bevacizumab. In conclusion, the authors concluded, and I support the conclusion, that pembrolizumab in combination with weekly paclitaxel, with or without bevacizumab, demonstrated, in their terms, statistically significant and clinically meaningful improvements in PFS, regardless of the PD-L1 status, and they demonstrated an improvement in overall survival in patients with PD-L1 expressing tumors. This was the first phase 3 randomized study to demonstrate a statistically significant improvement in overall survival with an immune checkpoint inhibitor regimen in ovarian cancer. They also noted the observed overall survival is among the longest that has been reported in any clinical trial in platinum-resistant ovarian cancer, recognizing the difficulties of cross-trial comparison. And clearly they suggested, and I agree with this conclusion, that this represents a new standard of care for patients with platinum-resistant ovarian cancer. Obviously, time will play out, who's going to pay for it, but I think this is a very impressive study along the lines of the impact that the original Aurelia trial had when it was first reported and then published in the peer-reviewed literature. And I thank you for your attention.